Now it is. Well, good evening, friends. Welcome you once again to this brand new episode of GICS Face Off, the Clash of Opinions. It has been quite a while that the Delta operator snatched Nicolas Maduro from his home in Venezuela, and later to that, the the threat to Greenland, so which flared up against Trump, the colonialism. Likewise, AI has also a big sphere of cognitive colonialism because it is also in a way to that it spares no one. No doubt, for a branch like critical care medicine, which operates in a complex milieu of multidimensional and multi-domain data, this AI seeks it's a fertile ground. So tonight, we are going to be joined in a very crusty debate on AI in critical care is more bane than boon. And on the to the support of this in the motion, we have most eminent speakers, Dr. Rajesh Pande and Dr. Urvi Shukla. And against the motion, we have Dr. Khusrav Bajan and Dr. Vandana Saluja. And of course, we have our regular jury, Dr. Kapildev Soni, Dr. Ajith, and Dr. Pradeep. So, without wasting any further time and seeking permission from the jury, I would like to request for the House, the members of the Treasury bench, Dr. Urvi Shukla, to present the arguments in her favor. Welcome, Dr. Urvi, and the
Thank
stage
you.
is yours.
Thank you. And at the outset, I would like to thank Dr. Pradeep Rangappa and the organizing team for inviting me here. I'll just share my slides. Okay. So I'm going to be speaking on AI in critical care is a bane. And in the next 15 minutes, I hope to convince not only the jury, but the delegates to understand why AI has created more problems for us. So I would like to start with this statement that this AI is an illusion of progress. And in we are often told that artificial intelligence is the next best thing to fire. And when we talk about fire, we know that fire keeps us warm, but when it is uncontrolled, it wraps up in its flames and destroys everything that comes its way. And the storm of AI that we are facing now, knowingly or unknowingly, is something like fire that is spreading without any limits. And let me put it in this way that AI not only influences doctors, but it also influences patients. And the way it influences patients is by misinformation. So we know that the social media and the amount of memes and false narratives that are spreading on the social media, not just about political information, but also about health information. And we before we can get across to spreading the corrective ideas, we know that misinformation spreads like wildfire, and it is very difficult to control the fire that has already started. And why does this happen? So, first of all, social media definitely spreads misinformation faster than facts. And most of the times, if you see this information, it has a very specific emotional appeal. Now, when AI sees this emotional appeal, it senses the emotional appeal. It does not sense the correctness of the content. And when that emotional appeal is there, it realizes that people are actually clicking on the forward button. That is where AI puts it on its algorithms, changes its algorithm so that more and more people are able to visualize that same meme. And what drives this emotion? A, we are an emotional population as such. B, the fear and the hope of getting some magical cures to some hopeless treatment or hopeless disease conditions, and the fear of losing out on something, or there may be better treatments about which we don't know, and therefore we are going to get stuck. When this information is uh, spoken by some influencers or by celebrities, or they are the ones who are acknowledging it, uh, people feel that it is most trustworthy. It is more like seeing is believing. And none of us, as doctors or in the medical profession, are out there correcting these false information that spreads around. We also know that it's very easy to give out an emotional appeal which may be fake, but however, spreading health information, which is so complex, which takes us almost 16 years to kind of get to a mastery, is very difficult to put out in a 2 second or a 10-second meme or a 10-second reel. So that costs us the facts, that costs us how patients come to us. We all complain of patients who have screened everything on Google or have questioned the AI and have got some answers, and they are looking for miracles. They are looking for miracle cures to help them get better. So, what I would say is emotions, they travel faster than evidence, and misinformation spreads when trust is at its lowest. And I think doctor patient relationship in the current era is at its lowest, and we are not doing anything to correct that situation. And therefore, we are lagging behind very greatly. And so I would just like to say, so misinformation is a false claim. And when it is added, when there is an emotional reaction that is added to it, this false claim gets shared rapidly, because more and more people are seeing it on their algorithms, which the AI are perpetuating. It gets reinforced. And because it is reinforced, it becomes, or it is perceived as the most correct information, or as an absolute truth. And along with that, some of us I mean, all of us, we are very resistant to correct it, and we get patients. Especially the classic example is COVID. It is not that we did not have epidemics in the past, starting from plague and polio, swine flu in recent times, MERS in recent times, and even seasonal dengue, malaria that we face every year. But the kind of media attention that COVID got, it was not just about the disease per se, but even the possible medications, the possible duration, the possible risks, and the possibility of how it would be spread. And we saw people, practicing dangerous things like washing foods with chemicals, drinking some hot kadas, doing jal neti, very unscrupulous use of steroids. People were hoarding remdesivir, and it was going crazy all over the place. So we not only faced shortages of medicines, but we also realized that when AI takes it on its algorithm to spread such news, it is extremely difficult to halt it, to stop it, and to put some sense and put out the facts, because nobody seems to be interested in how these facts work. So this is the problem with AI when patients come to us, and we are already dealing with this day in and day out, and we are answering questions not just based on patients' queries, but also what patients get on their mobile devices like their laptops, their iPads, and their phones. How do doctors see AI, or what do doctors want when they want AI in their setup? They want that the AI should not interfere with their resources, be it manpower, be it anything else. They want AI to be a silent partner, not noisy alarms, and not creating distraction. They want AI to explain the reasoning behind what is being put out, be unbiased. They want AI to be auditable, to be accountable, and to be accurate. And they want, all of us want AI to be controlled by clinicians, and not just a run amok situation. So, what do we get when we are talking about AI in the recent times? Um, uh, we get structural unemployment. We know, and I think most of us have read through American reports, through reports all over the in economic magazines, that AI is not just going to take away the jobs, but the speed at which it is going to take away this job. And the argument is that unlike the Industrial Revolution, where AI took away the hands, the physical labor, this time AI or this time it is going to replace cognitive labor, and it is not going to spare any specialty, let alone doctors, and even doctors, any specialty. So there are multiple reports which say 300 million job losses by 2030. Almost 20 to 30% of the repetitive mundane tasks will be taken over by AI. It will make it more efficient, more quick, more regulatory. There will be more automation. But what are we going to do with the junior doctors that we have here? If we don't have the junior doctors who are really the pillars of treatment, or they are our eyes and our hands in the ICU, we are going to be in big trouble, right? And that is what it says. Even for ICU, it means that teams are going to shrink, less junior doctors and nurses at your disposal. The managements will expect more productivity, because they will say, oh, automation has taken away half your work. How can you say there's so much work in the ICU? And AI, you may not become expert coders, but the management will definitely expect you to understand AI output, most likely want you to be an AI literate. Junior doctors are going to be very, very conspicuous by their absence, and that raises questions on what are we going to do and how are we going to train the next batch. Deploying AI in monitors, we have too many alerts, we have too many alarms, any which way that are going on. We all face the issue of alert fatigue. We have seen our nurses not listening to those alarms, where we are trying to remind them, look what's buzzing, kind of find out what's going wrong with the patient. And add to that maybe 10 more alarms ringing in different tones. And it's going to create a situation where they will just not listen to those alarms and probably miss out on a certain very critical alerts. Very importantly for all of us, it can cause cognitive atrophy. And by that, I mean we are going to become more and more dependent on AI to put out their algorithms, to put out their differentials, because it's just going to be a matter of seconds, probably a click on your phone, and you'll get a list of investigations that you need to do. And just imagine how we are going to test these students who come to us trained on AI. There's going to be no traditional or conventional methods that we'll be able to use when we test students and when we put our ICU patients in their hands at night, especially. There is a very serious risk of de-skilling these doctors, because they are going to become so dependent on machineries. And the I think if you have come or you have some colleagues working in the US, they are already suffering from this clinical decision support systems that have been installed in most of their ICUs. Uh, what it what it leads to is a reduced autonomy and a crying wolf phenomenon, because if your system is not well maintained, or if the guidelines change, which they do over a period of 3 to 5 years, every disease has a new guideline, and your AI systems are modeled on the old guidelines, you're going to land into big trouble. And obviously, when we talk about autonomy, we want to know who is going to be the boss. If AI is going to take over, then where does that leave you in the ICU? And the biggest problem, I would think, is the existential bane or the black box problem. So AI is not objective. It learns from human data, which is very, very biased. Our old sepsis models, other models have failed because the SPO2 model has failed because the training was done, the machine learning training models were cultivated only on Caucasian or fair skinned people. And when those models were tried across the population of the world, they failed miserably in patients with colored skin. So we have algorithmic bias. Who's going to be accountable? If AI makes a fatal mistake and we are blindly following that AI algorithm and something happens to the patient, who's going to be responsible? And therefore, there may be unintended consequences, because it is a very easy shortcut to understanding patient's disease, to understanding what investigation needs to be done, and to writing out a treatment plan. Finally, AI, it's very difficult to identify, and the problem of deep fake is very, very real. And I'm sure you all have seen the meme of Trump crying over not getting Greenland. So all these things are generated by AI. There are human hands to it, but it, and you know, it goes viral like crazy. So AI can generate very hyper realistic fake videos and audios. So you wouldn't realize whether, if you're listening to a commentary on a special disease, whether it's going to be true or it's going to be false. So you'll have to consistently and constantly cross check it with the literature. So I'm not sure whether AI is going to reduce the time you spend in the ICU or time you need to kind of come to a diagnosis, or whether it is going to make your life hell. And AI is going to definitely lead to death of privacy. So considering all these problems that we have, I think I can summarize this in this very beautiful sentence that was written by Edward Wilson. The real problem of humanity is the following: we have Paleolithic emotions, medieval institutions, and godlike technology. And it is terrifically dangerous, and it is now approaching a point of crisis overall. And I rest my case here. Thank you so much once again.
Thank you, Dr. Urvi. I think the last quote was an excellent quote, and you have very rightly highlighted certain points. One is the AI driven misinformation spread, and also linked to that is the inability to, or difficulty in distinguishing real from the fake, the duplicate, and a lot of it's the adverse influences. You have talked about the job loss, which is also a serious concern, because considering that AI replaces human hand in many of those areas. Alert fatigue in monitors, probably also an important point which you have highlighted. The cognitive atrophy that is a surmountable fear, and which might be a reality. And the lack of accountability, of course, because you cannot take AI to the court. In fact, if you have to sue, you have to sue the doctor who has been practicing AI. Now, moving on to go to the opposition bench. From opposition bench, now it is the turn of Dr. Vandana Saluja to join the debate and give her points. Yes, Dr. Vandana.
Am I audible, sir?
Yes, please.
And is my screen visible, sir?
Yes.
Okay. Uh, Good evening, respected seniors and dear colleagues. So I will be speaking against the motion of AI in critical care is more bane than boon. So emphatically, AI is not more bane than boon. And just to remind everyone, it is not emotion or social media, it is pure science. So, what does AI do faster, better, and smarter than what we do? So, it is a very good predictor. It can see what is coming better than what we can. And how does it do it? It does by watching patterns, by analyzing so much of data which the human mind cannot analyze. It helps in making decisions through complex data, and therefore it saves your time and optimizes outcome. So all these roles working together, it definitely enhances patient safety, and it is your support and it is not your replacement. So the first argument will be that how AI helps in life saving early detection. Now, why is early detection important? So that we can intervene early and more lives are saved. So let us see the evidence for this. So first is the role in sepsis. So here are the latest studies in from the year 24-25. I have quoted 3 studies which have shown us that it definitely detects sepsis earlier than the traditional scoring systems and helps us to optimize care of the patient and better treatment. So, sorry, the first study is by Lin et al., where they have only used 2 parameters, that is the CBC and the differential count, to identify patients. The second is a sepsis app, which is a prospective randomized trial in which they have predicted sepsis within 3 hours. The third is a meta-analysis of AI detection in sepsis. And what they have found, the highlighted study in this is the Kim et al. Deep Seps performing model, which had an area under curve of 0.93. It was based on a deep learning model and it outperformed the SOFA, SIRS, and MUDES in discrimination, especially at the onset of sepsis. Then we come to prediction of acute kidney injury. So both machine learning and deep learning models have been identified to predict sepsis at least 24 to 48 hours earlier. And this has been in adults as well as pediatric patients admitted to the ICU. So this is a summary of the AKI prediction models which have been found to have a reasonable area under curve to predict AKI in patients in the intensive care unit. Then we come to role in ARDS and mechanical ventilation. So AI has been very helpful in predicting the onset of ARDS as well as the various subtypes of ARDS and therefore guiding treatment. So the roles include early prediction and diagnosis, prognostic assessment, again subphenotyping ARDS into high versus low risk so that you can focus your efforts on the high risk patient treatment responders versus non-responders. Then again, inflammatory subtypes like hypo or hyperinflammatory in patients who might benefit from steroids. Physiological subtypes which may be efficient versus restrictive, recruitable versus non-recruitable, or dry, wet, and fibrotic. Then again, role of AI in mechanical ventilation, it helps in PEEP optimization, detection of asynchrony, guiding lung protective strategies, predicting which patients might require prone ventilation as well as ECMO. Other roles in which AI has been found useful in ICU is the delirium prediction, antimicrobial stewardship, glucose monitoring, and hemodynamic instability. Our HPI model, which we are using by Edwards, that is also based on algorithms. So algorithms are in use since a long time, and we have been relying on them since a long time. Now, the second argument in favor of AI is superior diagnostic accuracy. So here I will come back to our country where AI is selling like hotcakes. So we have two studies. One is from GG hospitals in which they have developed AI-based model to detect bacteremia in the blood. They have found that the model had a 90% sensitivity and 100% specificity when it was compared to blood cultures in early detection of bacteremia. Then we have the Edge AI network, which has been used in a multiple of hospitals, including Apollo Hospital. So this gave 4-hour early warnings as compared to clinical judgment. So now we will just see how the Edge AI network is already in our country and how it has helped us. So what is this Edge AI? So we have concerns like privacy, which ma'am said. So the Edge AI is putting the AI in wearable devices, which is on the patient. So the data does not go to a central monitor, but it is at the site of generation near the patient. It may be the monitor, it may be the infusion pump, or it may be a pulse oximeter, which is on the patient. So data is safe because it is generated next to the patient. It is analyzed over there and it is continuous. So real-time decisions are based on that. So we already have one hospital which has used it, which has used the Jetson Nano and TensorFlow Lite for continuous ECG and vital monitoring. And what they have found is that it was associated with a 4-hour early warning sign and a faster intervention. Other age AI case studies, not only urban but rural areas also, it has been applied. So it has been used by Narayana, it has been used by our own AIMS Delhi for fall detection. So basically, how did it maintain privacy during fall detection? What it detected was only the silhouette of the patient, no live videos. So they gave 200 time real alerts and 95% accuracy. In the Tata Memorial Hospital, it was used for drug dispensation. So maintaining the pharmacy records, identifying possible drug interactions and better drug dispensing. So it reduced errors by 35%. In Assam rural clinics, the Edge AI technology was used for screening and it identified at least 280 critical referrals and therefore saved lives. The third argument is how AI improves work efficiency and cost savings. So as a country, as a nation of doctors, we are already having facing a shortage. So I don't think there is any problem of anyone losing. Rather, we need to increase the efficiency and devote more time to clinical care. So that is what AI does. Now, how does it do it? I will tell you. So again, we start from our country where we are working. So there are, one is Edge AI, which I spoke about. The other is the Cloud Physician Network, which is an AI platform. Okay, it is currently functional in 22 states in more than 100 hospitals. So it is providing 24 by 7 virtual intensivist support. It is monitored by expert intensivist, which the main office is based in Bangalore. And it has found to reduce a 30% operational cost and reduction of 40% mortality over. Now the data is 1,30,000 patients whom they have treated. Apart from that, the Edge AI, which I have discussed, that reduces the nursing workload by 70%, because many of the things like, recording data, managing discharges, all this paperwork which is done is managed by AI. So the clinical staff can dedicate more time to patient care. So, Cloud Physician Network coverage is 22 states with more than 100 hospitals in the country, served more than 1 lakh critically ill patients. The core technology is known as Radar, and it has 4 important tools which generate notes, which make discharges, which help in monitoring. Okay, and the 24 by 7 virtual intensivist support is via Google Meet and chat. And the primary function, it is a remote monitoring system, so we are able to extend critical care even to remote areas where it cannot be afforded. The workflow efficiency is better. There's a 30 to 40% reduction in routine monitoring. The decision time is faster, and there is a higher productivity per clinician or per nurse because of task offloading. And therefore, there's a considerable reduction in doctor nurse anxiety because of continuous AI oversight. Now, the Apollo Hospital Edge AI monitoring, which I have mentioned, that monitors 3 things, that is ECG, oxygen, and respiratory rate, detects the warning signs at least 4 hours in advance, and there is a zero latency for critical alerts. Now, there a problem of alarm fatigue was discussed, but this technology has the capability to detect movement as well. So instead of increase in alarms, there is a decrease in false alarms with this Edge AI ICU monitoring. So, in summary, the evidence is clear. With AI, we have superior accuracy, we are saving lives via early detection, and we are solving our country's intensivist crisis. Okay. So, the future is not AI replacing doctors, but rather doctors who can leverage AI replacing those who cannot. So, please get on board. And as Charles Darwin said, it is not the strongest of species that survives, nor the most intelligent, but the one who is most responsive to change. So AI is here. So we all need to get on board. Thank you.
Thank you again, Dr. Vandana. You have highlighted very strongly certain points, particularly the one because you have said that it enhances patient safety and clinical support because of mainly through early detection. Early detection is because of early prediction and because of algorithmic based processes, and it improves work efficiency and also reduces the costs. And the newer AI tools like Edge AI, they are safe, they won't cause any alarm fatigue, etc. So thank you very much for making your relevant points very subtle and clear. And now I move on to the member of the Treasury branch, and this time it is Dr. Rajesh Pande. Vandana, you have to unshare your screen. Pande can, yeah.
Is my screen visible?
Yes, yes, sir.
Well, I'm speaking for the motion, and my younger colleague, Dr. Vandana, spoke very enthusiastically. See, the problem is we doctors are gullible people. Pharma comes and says, this is good, this is good. We start writing, prescribing. Many of the molecules that we write are India specific only. The same thing applies to the wider application and our belief in AI. So I'll try to address the problem by looking at the origin of AI. And, you know, uh, the interest in AI is growing in science also. NEJM also started or yielded to the pressure and started in 2025 January the NEJM AI journal. So there's no way we can escape the AI. But we need to understand what it is, how it will impact, and what adverse effect it has. So what is artificial intelligence? It is a computer program which is associated to execute, which can execute tasks like human intelligence, like reasoning and learning. It can adopt, do sensory understanding and interaction. That is what it is. The problem is traditional computational algorithms that we use, like the calculator. You put some input, then you get some output. AI system is different because it will learn the rules. So that is the function, and it will learn the route through the input, which is the training data and exposure, and then it has the potential to change healthcare by producing new essential insights into vast amount of data that we create in healthcare delivery. So that is the belief. So artificial neural network, which is the core, which is so much talked about, is a conceptual framework for developing AI algorithm. It resembles the human brain model of interconnected neurons, etc. So that is said to be good. People talked about deep learning and machine learning models. That is how it can learn, and then it can produce the output. But the problem is the data is huge. That is why we are calling it big data. So this data, selective or non-selective use of this data, will become new source of inaccuracy and data breach. Healthcare is a high-risk area. Our critical patients come to us when they are most vulnerable. So AI-related mistakes and errors can have severe consequences, including death. Prediction is easy. You can say prediction has, last time with the same algorithm was 50%, now it is 70%. That's not going to kill your patient. But when it comes to actionable AI, that has the potential to kill the patient. And people are talking about actionable AI. If you look at the big data, well, collection, usage, storage, these are the usual things. And now you will have to employ a third-party vendor in AI-based healthcare solutions for integration, development, data collection, aggregation, AI system monitoring, maintenance. Although there are some advantages, but the possible risks are you are sharing the patient data. There could be negligence. Data transfer and ownership would be a big issue. You do not have direct control over this data. Ethical standards between your organization and the vendor may be different. That the people have proposed a lot of things how you can protect the privacy of the patient. Most of them are, I would say, aspirational, theoretical, because studies have shown that there are retrievable algorithms which they can de-identify the data, and in adults you can have the information about 85.6% of the population, in children 69.8%, very high number. So that means they have tools to de-identify. So where is the privacy then? And there is a lot of bias. These systems are designed in a way that makes the system use the bias means AI systems can use decisions based on which are unfair, or they are using the system in an unfair way. So important bias is exclusion bias. Dr. Urvi alluded to this. Data is missing. It is not complete data. It is urban data, not rural data. Underrepresentation. If you look at the race, caste, creed, gender, it may not be included. The data may only be available for socially privileged people, those who can afford insurance. Other people, there may not be any data for. So you get selective analysis of the data. Those who do not have access to care, their data may not be available, may not be analyzed. So this was again highlighted by Dr. Urvi. And there could be empathy bias, because it's a empathy-less system. So patient preferences, human stories, what the patient is telling us have no value, so they do not matter. And of course, there could be evidence bias. These methods have been suggested that the data inclusive practices should be there, ethical framework should be there, but these are largely, I would say, aspirational, that we should do this. How we'll do that, that's a big question mark. Another thing that, fake imaging, etc., that Urvi referred to, generative AI. Now, it's the keyword now. A lot of industries using it, especially the social media, the movie and TV industry. It uses data lakes and question snippets, billions of parameters. They are constructed by software processing huge archives of image and text. So AI platform can then create rules and make judgments, predictions when responding to a prompt. It works like magic. There are solutions available, Stable Diffusion, Midjourney, Dale E2, that can produce remarkable visual in styles from old photographs, watercolors, pencil drawings, much faster, much better than human beings. But how, whenever all of us are using a phone. So, oftentimes there is an upgrade because there are bugs. So it is a debugging upgrade. You can't debug a billion parameters like you do in ordinary software. So AI risk goes beyond incorrect answers, fabricated citations, fake case references. Youngsters are using it, almost day in and day out. So they're using it as emotional companions, sharing their deepest anxieties and fears. AI may respond in a harmful way. You know the TikTok story. Such failures can be reduced but not prevented. That is the fear. Another big issue is ethical and legal provisions. Are they enough? This was alluded to by Dr. Anirban Choudhuri. Modern computed processes hide the thinking behind it, how it is predicting, how it is telling you that this is right, this is wrong, it is 85%, 90%. That is opaque. This is black box issues which we would not be able to understand. Even the data scientists, all of them may not be able to understand. So it's not visible to evaluators, doctors, or the patients either. Does the scope of AI fit within the legal categories? That is a big question, or we need to create a new category. There are four major ethical concerns: informed consent to use data, safety, transparency, algorithmic fairness, biases, data privacy. Now, there are also intellectual property issues with AI. I'll illustrate with an example. Diagnostic AI algorithm has been created for CA colon. What should be protected or patented? Foundational data set, training process to create the algorithm, decisional algorithm. Should it be a trade secret or a copyright, which has the potential to last indefinitely? We don't know. So World Trade Organization members have to provide patent rights under trade-related agreement on intellectual property rights. So, but there is some scope for the country to modify this in their own way so that their citizens are benefited. So this is a gray area, and generally if you are applying for a patent, then the average time is 3 years. By 3 years, the algorithm may have been modified 30 times, may have been upgraded, because or more data is available and that has become obsolete. So this is another problem. And there is significant potential for misuse. There is vulnerability in cybersecurity. We know even my hospital was attacked. So there was a human skull that was seen. They asked for ransom. New attack vector based on data died vulnerabilities is a real issue. State using AI to control citizen surveillance using predictive police algorithms. Citizen fundamental rights may be jeopardized. Feasibility design, ethics of lethal autonomous weapon system laws. Morality of developing and implementing such system is questionable. You must have seen, or you must see if you have not seen, the Mission Impossible Final Reckoning. Ethan Hunt and IMF pursue a dangerous rogue AI called the Entity that's infiltrated global intelligence to destroy humanity. This is, it's not a impossible thing. This may happen. People have also focused whether the current bioethics principles that we apply are enough to control or safeguard the humanity from, or our patients and the doctors from the effects of the AI. There are a lot of negative considerations and there are some positive, but again, it's again a framework. Nothing definite has been done about it. I will illustrate with two examples from cardiology. A young man has an undifferentiated cardiomyopathy, moderate LV impairment. There's a diagnostic challenge that the cardiologist is facing, and prognosis remains uncertain. They are not very sure. Medical therapy response is suboptimal. So AI-driven algorithm predicts that patient prognosis is high risk for sudden cardiac death and recommends prophylactic implantable defibrillator as first-line treatment, despite near normalization of LV function and absence of significant arrhythmias. Now, cardiologist is confused. What should be done? It's a young patient. The issue of infection, inappropriate discharge by the ICD, and need for repeated generator changes, all those issues. So transparency, whether he should disclose the risk of SCD provided by the AI program to the patient, but he cannot explain the algorithm. And what is his role? Like Dr. Anirban, in his remarks said that who is responsible, who will be sued? Accountability. If he goes ahead with this, he is a person who you can catch. He is accountable. The algorithm and other things, maybe, they are global in nature. You see what the Elon Musk Grok is doing. What have we done about it? Nothing. So they are sitting there. They are far too powerful, more powerful than countries. Second scenario, an old man, severe calcific aortic stenosis, a TAVR is done. Patient is considered high risk and eccentrically calcified aortic root is there. Intervention cardiologist has used AI-driven CT model, which can predict the optimal position of valve and maximal inflation pressure. This is done. However, the patient goes into shock. T shows new pericardial effusion. Pericardiocentesis is done. Coronary angio is done. But ultimately, the patient dies, has a cardiac arrest, and he dies. Now, the question that comes is informed decision making and consent again. The patient must consent to procedural decisions made by AI-driven model, and we have to explain that there is limitation because we also don't understand how it has come to this conclusion, and the clinicians training and level of AI inability to use it appropriately, that will be depend, like Vandana referred to as those who are AI naive versus those who are AI trained or AI enthusiast. Accountability. Now, who is accountable? The cardiologist is for sure liable for potential harm, but whether the model responsible or the company making it or the formula, we don't know who to catch. So there are concerns. Balance between ethical issues and legal issues is to be maintained. Regulation, privacy, bias, transparency, relevance, legal governance, confidentiality, liability, accuracy, decision making. We have not been able to do anything to Meta, to X, or to any of the big social media global companies. So they are evolving very fast compared to the laws that we are making. We do not have. If you look at us, can we evaluate a paper where the author says or the group of authors says that they have used AI and come to develop this model? We can't. So to conclude, I hope that this AI development will also fall into the Gartner hype cycle, where currently possibly we are at the peak of inflated expectations, and sooner or later we will have trough of disillusionment, and we'll come to an area where it can be utilized. So for mundane things, for reducing the stress, possibly plateau of productivity will come. Thank you very much. I rest my argument here.
Thank you, sir. Dr. Pandey has highlighted the source of inaccuracy of the data breach, particularly with related to big data and the privacy issues that encompasses it. He has talked about the bias because of unfair way of using that, because which can be a problem, serious problem is AI. He has also talked about the empathy bias that exists in such systems. He has spoken about the fallacies of generative AI, which influences the social media and where debugging is a problem. He has spoken about the black box issues, which are not amenable to evaluation properly. And of course, the intellectual properties and their misuse. Thank you, sir. And now we have from the opposition bench our last speaker in against the motion, Dr. Khusrav Bajan.
Thank you so much, Anirban, and thanks, GICS, for having us over today. I'll just start sharing the slides, if I may. I'm sure it's all visible.
Yes.
So, being the last batsman, I probably need to hit sixers on every ball. And Rajesh and Urvi have really sent across a lot of googlies. So, let me address AI to the best I can. And also later, if time permits, a little small rebuttal on what they have done. So, I would start here by actually saying that AI is the present and AI is the future. And AI is definitely a boon of the century, not today. I just want to make a few things clear. This is a very nice slide which actually discusses human versus AI memory. So human memory at best, the like maybe Rajesh Pande or somebody would have 100 terabytes or even petabytes, but the working memory is much smaller. This memory is usually imperfect and associative, and it can decay with age. We have not reached there yet, hopefully. And there is a cognitive processing which can do simple tasks, but multitasking becomes difficult. As against that, an AI storage memory can go up to zettabytes and even yottabytes, and they have a perfect recall. So sometimes for us to remember names is difficult. So remembering algorithms and other things might even be a bit difficult. So here you have a perfect recall and you have a scalable hardware. And here exactly you can see the entire bytes here from gigabytes, megabytes to even yottabytes. And as already mentioned, it is a comparison of doing a mental math versus doing a using a calculator. The disclaimer is that AI is here to stay, and hence I'm not having a debate here today, but rather will mitigate the apprehensions of my colleagues that we have heard with statistical data, which Vandana beautifully expressed, and the real world evidence of paramount benefits of AI in critical care. I'm not going to talk about media, I'm not going to talk about anything else, but basically critical care where I belong. So the beginning of the era, it is called, when AI was started by John McCarthy, who is known as the father of AI. And the AI definition was technology to simulate intelligent behavior and critical thinking comparable to a human being. So AI has not been brought into this era for replacing a human, but to try and mimic a human and aid the human in every possible way. From then on, you can just see the evolution of AI. So AI is always evolving, and I hope we all doctors are always evolving too, trying to do the best for our patient. So in 2010, you had a medical imaging, then you had predictive analytics, then you had robotics coming in 2015, and then you had AI-driven administrative tools helping even discharges and admissions to happen in the ICU. Personalized medicine came in 2019 because of the early interventions and the early diagnosis and prediction, virtual health assistance, and it goes on and on. And now after COVID, we realize the importance of even telemedicine, and it's just growing. And therefore, I would call it a game changer. I would also call it revolutionary, and I would call it compelling because AI can reduce diagnostic errors by 85%, streamline administrative tasks to save 20% of human or healthcare provider time, and personalize treatments to improve patient outcome, which is our sole aim, by 30 to 40%. So how does it do that? There is multimodal model. I purposely put it this way because it's a tongue twister and I could manage, not with AI help, but my own human intelligence. The predictive capability is then converted to an integration of all technologies, and then an automated output is formed. And here you can see a typical ICU patient where there is device management, there is pulse ox, there is ECG, there is blood pressure, there is so much more vitals. There will be warning signs. There would be a treatment choice given to us. And finally, it is the doctor who is going to make the choice. There will be communication with the patient and taking them into confidence. So there will
It's
be
me.
transparency. And then there will be a database building for the new generation doctors to follow, depending upon the marriage between the AI and the human doctors. So in healthcare, already mentioned by Vandana, but the utility in healthcare is endless. But it not only improves diagnostics, it helps personalized treatment. It also helps drug deliveries. We are talking of AMR, and we have empty pipelines, right? So we don't have newer and newer antibiotics, and we have more and more AMR, which is going to kill patients more than any tsunami. So, therefore, drug discovery is supposed to be the pivotal thing in the next 10 years or so. And if we can get drug discovery done very quickly at 1/10 the time, not years, then it would definitely help to fight the biggest menace, which is drug resistance. enhanced operations and administration, robotic surgeries, and patient monitoring and access, and then finally fraud detection, which I will discuss a little in detail later. So there is an endless possibility if you involve AI in your healthcare. These applications have already been covered by Vandana, like early diagnosis, risk prevention, continuous monitoring, early warning signs, workflow efficiency, cost benefits, and I'm not going to reiterate the same thing again. But I would just draw your attention to a few important points. There is precision and personalized medicine that we can offer using AI because we can tailor the treatment, individualized treatment can be given, we can support phenotypes, and we are definitely going to move away from one size fits all into a personalized, individualized treatment. There is definitely a reduction in medical errors. You minimize the prescription errors as also already shown, and you are doing a good checklist. There will be a drug-drug interaction. Earlier in my days, I had an app called Hippocrates, and I used to follow that even before we talked about AI. I'm talking of 10 years ago. And even if you are giving medications to your parents and you don't know what interaction might happen, you can just put two drugs and it will tell you exactly that they can be or cannot be used. So there is an endless possibility which is going to help you. It standardizes care and it enhances patient safety by reducing medical errors. Other few points I really want to bring out is there is workforce support. It is supporting us. It is not replacing us. And therefore, definitely burnout reduction happens. And instead of alarm fatigue, which leads to burnout problems, we are actually reducing the burnout in doctors, nurses, and fellows. There is telemedicine. We have the hub and spoke, and you can easily control a lot of satellite areas and reach the rural areas where the care may not be same. You may not be able to clone 10 Rajeshes and 10 Urvis, but you can definitely have them sitting at the hub and controlling a lot of satellite areas run by maybe Khusrav and Vandana. We can have simulation based training, and we have a nice new term called as digital twin. It's not cloning, but the exact patient that you have on say bed number one with sepsis and ARDS and AKI can be mimicked, and a digital twin of that patient can be made by AI, and it will give you a reaction that if you give this patient fluids, what would happen, and if you give this patient diuretics, what would happen. So it is going to definitely help us. It definitely helps us in prognostication because many a times we may treat well, but telling the patient's relatives that they are going to have 5% chance of survival and versus 15% chance of survival, how long it is going to take would be extremely easy with an AI prognostication tool. And then we have collected all the data with EMR, and therefore this data is going to help us in research. And we talk about India lacks research, but this is our opportunity to get data and get more research. So the interesting words or the stylish words here when we incorporate AI into our practice is reactive. We react to a argument, we react to somebody whilst driving on the road, and we may, being a Parsi, you might use a lot of foul language, but we are not reacting here to something that comes and hits us from the patient as vitals, but we are proactive. So there are new paradigms, there are new biomarkers, there are new everything else that actually makes us proactive, and that definitely would help in the management of our patient. All predictive is now becoming actionable. So you predict well, and then you have actionable AI, and that actually rules out all the other bias that may be involved because the AI system should be the one which you adopt, should be completely flawless, and it can't be completely, but as flawless as it can. We always talk about strokes and MIs and sepsis, and we say that time is brain, time is muscle, time is tissue, time is organs, time is life, and I would say time is AI as well. And as you can see, these two small cases, One is in trauma patients, polytrauma. If you only look at the injury severity score, you cannot predict that this patient is going to have ARDS. But if you actually look at the AI tool, you can predict ARDS in a particular patient or a group of patients that they are going to go into ARDS, confused lung, etc. And therefore, you might fall back on your fluid therapy. Another case here where you have a sepsis patient and AI can actually detect 12 hours early. It's called the window of opportunity. And this will decrease your hospital mortality by almost 21% and your hospital length of stay by almost 3 days. So I think there is a win-win situation and it saves your time rather than wasting time. Let me be the devil's advocate. And here again, Al Pacino and Keanu Reeves are also using the letter A, probably for AI. And let me try to put the apprehensions that they have quoted in their talk at ease, trying to give you the right and fair picture of AI. I've repeatedly heard from my colleagues that AI has a black box. So whatever you have an input, you get an output, and you have no idea what happens in between. So yes, black box is a problem with AI. But my friends, there is a very easy algorithm where you can interpret it and you can explain it. And this model can overlay the black box model and have a proper output, which is completely reliable. I always believe with the black box, I would extend here by saying what goes in comes out. Now, don't start thinking of other things, but whatever be the input will be the output. And here, the input is used as a word called as prompt. Now, this in light vein is a very nice kind of example that I'm going to give you. And suppose I had a lecture on COVID and I asked the Copilot or ChatGPT or Gemini to give me a type of sari for a talk. And guess what I get? I get a sari here. So I don't know what talk I will give because the AI does not know I'm a doctor. I have not specified that I need to give a talk on the full form of sari. And therefore, instead of giving severe acute respiratory infection data, it has given me a sari. And we use the word Python a lot. So the Python in AI gets confused and gives me a Pythoni sari, which is a type of Maharashtrian sari. So what I'm trying to say is you have to be intelligent enough to give the right input and then you get the right output. So the black box is only a delusion and it's a myth. We also say that just like humans, an AI can hallucinate, and that is called as confidently incorrect outputs are generated by the LLMs, and this can happen with Gen AI, which was alluded to. So you can have formulas or 8 steps to actually fight this AI, and that is through model validation, explainability, data quality, continuous monitoring, and so on and so forth. But most important is the second point, that is human oversight. So always and always, a human has to validate whatever the AI tells you. Another myth, I'll just take 3 more minutes. Another myth is it loses humanization and there is no empathy. So the AI has actually upgraded itself, and now there is not only agenetic AI, etc., but there is empathetic AI. It understands the emotional recognition, it does contextual understanding, and it actually simulates the empathy. And a good software for that is Spike, which actually is a human centric interaction and it simulates the emotional understanding. So, yes, a human touch is definitely important. I wouldn't say that I won't stand at the bedside, but maybe I can use the empathetic AI to understand and use the right language to explain to the patient's relatives. Another myth which was alluded to by Urvi says that it takes away our jobs. I'm not talking of other jobs. I'm talking of doctors. So here you can marry the AI and call it a hybrid intelligence. So always hybrid is better. You have cars now which are ICE as well as they are electric. And similarly, you can have a hybrid model and you can have artificial intelligence plus clinical expert, and then that's 100% win-win, and you can have the best optimal patient outcomes. So I would say here, friends, there is a little more, bear with me, but AI for sure will not replace doctors. However, it is highly highly probable that AI will take away the jobs of doctors who don't embrace AI. And I would not call it artificial intelligence, but I would call it assisted intelligence, and I would call it augmented intelligence, again, to a human being. One more myth that I will cover before I end, that is medical legal liabilities. But we all should be aware of this rule, that is the DPDP rule, and that is Digital Personal Data Protection Rule. So it talks about the privacy, and it is very, very good because the AI companies which are coming up and selling themselves to the hospitals would obviously be equally protected for data privacy, and there are many multi-layered ways of doing that. I will give you an example. Nowadays, you may get a medical legal case, a customer care complaint, and these complaints, I have also received them where the person only says that, okay, bleeding was ignored in the ER or in the ICU. And that can be an entire complaint, which the words are so brilliant that you feel that somebody very senior has written, but it's an AI generated complaint. So you can also use the same complaint in trying to give a proper response to this. And sometimes in court, they might ask you that, have you followed the AI? I'm not talking of now, but maybe later as an expert opinion. Not because I am so much for AI, but because AI will look at not one algorithm, but 10 algorithms. It will update itself to the latest, which we might be missing, and will give you the data. Then how to use it is our problem. Now, I will come to the real world data, no more discussion. Medical imaging and diagnostics, a lot of my radiology friends would agree that there is 94% accuracy in breast cancer detection, predictive analysis in hospital readmissions, 20%, list goes on. Personalized medicine, administrative problems, scheduling systems, robotics, and patient query response time. So it is a lot of mess in our world of hospitalization of a patient, but there is an AI which in the real world actually helps. And this, in a nutshell, in my this slide, AI in critical care can have the right setting in the intensive care, can educate the doctors, do simulation techniques, do a digital twin, help them in clinical application, take the problems of the technical objectives away, and then start an autonomic AI or an adjustive or assisted AI. So I would say, friends, that convert your information into knowledge and then convert your knowledge into wisdom, because we need to be wise doctors and take the right decision. So I end here with a quote by William Mayo. I'm not sure who he is. The glory of medicine is that it is constantly moving forward, that there is always more to learn. The ills of today do not cloud the horizon of tomorrow, but act as a spur to greater effort. And yes, I would end here by saying AI is a significant boon in healthcare, revolutionizing diagnosis, treatment, drug delivery, discovery, and operations by improving accuracy, personalized care, reducing costs overall, easing the staff burden through tasks like predictive analytics, image analysis, decision making, and leads to better patient outcome. When doctors and AI will work in sync, together we will be able to provide precision and personalized medicine to our patients, because AI only augments our practice and never replaces it. And I rest my case here. Thank you, friends.
Thank you, Dr. Khusrav. I think that covered the entire spectrum of all the possibilities to an extent that he gave it is no longer an artificial intelligence, it is an assisted intelligence, an augmented intelligence. And I was while I was listening to him, I was also thinking that probably it can be a good idea to have a debate with Gemini and ChatGPT on one side, and with Perplexity and some other platform on the other side, and see how they discuss and debate on this particular issue. Thank you very much. Before we move on to the jury for the final verdict, I would like to request, if anybody is interested for any rebuttal. I will start with Dr. Urvi. Dr. Urvi, are you for any rebuttal? Then I will go to Dr. Vandana, and then I will go to Dr. Pandey with 1 to 2 minutes, because
Yes,
Dr. Kushi. Yeah, Dr.
I
Urvi.
have one sentence to say. I think Dr. Bajan's talk was a really feel good talk about how ICU work for intensivists is going to become stress free. And I really feel that this utopian state is not realistically possible. And I only want to ask everyone here on this platform one question. If you are a patient, do you want to be treated by an AI generated algorithm where the doctor tells you that, oh, look, 20% of the work I'm doing, rest of the work the AI has done for you, and therefore we shall follow what the AI tells us?
Dr. Kushra, would you like to take a rebuttal for the re-rebuttal for that? If
Yeah,
you would.
thank you. Yeah, so basically, AI is going to help me to make my decision. And if I, like Urvi would say, tell the patient that I have used AI to help you out, then I will not be paid for my work. So I definitely will not be doing that. And I would use my AI, but I will definitely not tell them that AI is teaching you or treating you, but I will use the AI to my betterment. I also want my bread and butter. So Urvi, I will
So you will
use
reserve
the
your
AI,
honesty
but
for that.
I will be transparent and I will say that I did use AI for my this thing. So it's like a second opinion. They say that medicine is allopathy, homeopathy, sympathy,
And
but
empathy.
finally it's Googleopathy also. So now AI is there to stay, and we need to understand how to use it well. It's always the tool. A tool doesn't matter. It's how you use the tool that matters.
Dr. Vandana, would you like to have any points for rebuttal? If you
No, no, sir. Actually, sir
okay,
has covered all the points
okay,
very
Dr.
well.
Pandey, Dr.
Thanks.
Pandey. Yes, you are muted. You are
Muted.
muted, Pandey sir. You have to unmute.
Yeah. Am I audible now?
Yeah.
Yeah.
Okay. I believe AI can perform mundane tasks faster, accurately, but when it comes to very critical, extremely critical tasks, whether we can really believe the results, because if somebody's life depends on it, that's a questionable thing. My friend Khusrav has very enthusiastically said that for everything, anything and everything, AI is the solution, and it is even the black box. He was so enthusiastic that there is nothing wrong about the black box.
There
Now,
is nothing black in the black box.
this is all about data. If you look at the algorithms, how much data is available for the algorithm developers, data scientists to develop their models? Very, very limited data. So if they have large body of data which is not available because of data accuracy, because of sorry, data privacy and data security, then the algorithmic results would be completely different. Look at the studies where the FDA asked them to increase the number and they could not show any benefit. Uh, like for this recombinant factor 7A for the neural bleed. And another important thing is, uh, this AI application, the people who will have the data, like insurance companies, they have huge data in US, how they are utilizing it in an unethical way. They are applying it to identify patients who will overstay, simple pneumonia cap coming to the hospital, overstaying, and what are the factors that they can identify the patients who overstay, and then they will either deny those patients admission or they will increase their insurance because, and again, the like I highlighted, the model is as good as the data set it is using. If you are not including all the members of the society, say for example in a very populous country like India, your data is very, very skewed. If I give you max data, that you take this data and this is the algorithm you can apply to everywhere, all hospitals, that will be foolhardiness. So that is a concern, and whoever has the data is the king. So that is why you go anywhere, they are asking you, what is your, give me your phone number, give me this, and then you have a 100 rupee discount. So I think uh, self-evolving algorithms would be another big problem, because which way they will involve, we may not have any control. Khusrav talked about human oversight. Which humans? If he's made the head of a committee to oversee something, he will need data scientists. So those who are developing, their brothers will only be doing the oversight because we do not understand it. A paper comes to the GICS journal. Will my friend Pradeep be able to understand if it is AI based? He will have to consult somebody who can understand the logic and the merit of the paper. So it is the unknowable thing which is my concern. It is the wrong use of the data that is my concern. It is the inaccurate result coming from the data that is my concern. And what is good now, 5 years from now, the science is changing, the data analytics have also changed. We find that we kill more patients, and now things are completely different. So I rest my case. This is my concern.
The doubts generated by AI can only be sorted through AI. I think that's only. Well, Dr. Khusrav, any
No,
points for
just
rebuttal?
last one word. See, we had simulation happening since last 10, 15 years. So we need a simulation engineer who will actually make the dummy or the mannequin vomit or the mannequin go into an arrest or a cardiac arrest rhythm. But finally, the doctors run the simulation program by their knowledge. So this is very similar. We are a little worried because AI is something we don't understand. But when we say human touch, it doesn't mean always doctors for healthcare AI. It also means the data scientists and the ones who have made the program. And we have to just tell them that make it kind of foolproof, make it transparent, make it doable and usable, and make it proactive. So, yes, I agree with everybody that it cannot replace a good CPR session or a good polytrauma management. But yes, when you get at least a few minutes to try on, you can definitely use the AI appropriately. And there finally has to be a human insight towards the whole thing. You don't have to follow it blindly. Urvi had once mentioned that you follow it blindly and you might land up in problems. The only time in medicine I use the word blind is for a double blinded study.
Oh, that's great. So thank you, Dr. Khusrav, thank you, Dr. Pandey, thank you, Dr. Vandana and Dr. Urvi. So we had heard from all our debaters the issues they have raised, and they've placed their points. And now I move on to the jury, and I start with Dr. Kapil. Quickly, Kapil, you have heard both the members of the Treasury bench and the opposition. So give your final verdict
Yes,
quickly.
yes. So first of all, I agree with both sides of argument. Yes, the AI is there, and it's now whether we like it or not, it's going to be part of our life, and this is going to be increased much more as we age further. Uh, as I see the problem with AI, I always reminded me of that quote which Uncle Ben said to the Peter Parker: "With great powers come great responsibilities." So we have powers now, but responsibilities are they are yet to be decided.
Okay, great. So there is one more term other than cognitive atrophy. I think that needs to be highlighted here is called that cognitive hegemony. So I think that surmises your comments. Dr. Pradeep, your final verdict quickly.
Yeah, at the outset, congratulate all the esteemed debaters, Urvi Shukla, Rajesh Pande, Vandana, and Kush. So very nicely elucidated. Literally, it was a very comprehensive coverage of both sides of the argument. So as I said, I think someone messaged Shanti Raja, who's my good friend, who's from Australia and US. She's been all over the world. I think she made a very interesting remark. I think the data, which Urvi so nicely mentioned, data is what determines your algorithm, and the algorithm is what is guiding you. And that data, what is fit, rubbish in, rubbish out. So that may be even harmful. So who is validating? I think that becomes a very primordial question. Are we putting lives at stake by depending on fallacious sort of a data that may have been fed unintentionally? Of course, it's not intentional. So there should be checks and balances. So I completely agree with Kapil. No matter how much we debate, the future is written very much evidently on the wall that AI is here to stay, and they are going to decide on certain decision making, because the number of data points at this point of time, as I'm speaking, we deal every hour is 1,000 data points we deal in ICU every hour. So it is humanly impossible for us to accurately synthesize the data and make logical sort of a decision. So for that we need. So it is an adjunct. It is here to stay. But my submission is there should be checks and balances, and there should be a validation cell which validates the algorithms generated, considering the black box effect in this whole algorithmic approach, Anirban. But well done. I think all the speakers were brilliant. I really enjoyed the session, Anirban. Great
Yeah, so
talks.
Pradeep also believes in assisted intelligence, which was pointed out by Dr. Khusrav. And moving on, final jury, Ajith Kumar A K. Yes, Ajith.
Yes, I joined a bit late, but yes, whatever I listened, there's an excellent argument from both sides, and I cannot disagree with them as well. But when counting everything together, I believe that we need to utilize both the, like few of the speakers have mentioned, both the artificial intelligence, both, and the human intelligence to get an augmented intelligence, with the final call being the human intelligence. What I mean is that the both are important. The artificial intelligence has to be used and human intelligence has to be used. It is going to be an augmented intelligence. But with the final call, in that version, I'll say the final call has to be with the human intelligence. That is very important. And obviously, when there's still a long way to go. Like all scientific inventions and all, moving forward, there's a long way to go for the AI implementation. One major thing, right from social issues, like, humans have got some kind of human inertia, in the sense, people don't want to change what they're doing. Like, all the humans, including public, government, all of us are there. There's a inertia itself is there. There are obviously a lot of, other issues. You should have the electronic, records has to be there, and there should be genuine data. The recording has to be proper. The data is wrong, mean whatever the data output is going to be there. And obviously AI related issues, a lot of discussion has happened, and including the privacy, ethical issues, and all that kind of things. But still, AI is definitely going to be useful as an assistant, especially in the critical care settings, because it can reduce the burden of the doctors. I may say that at least 10 to 15% reduction you can expect. That's what my guess. Writing the notes and all, and clinical decision support systems, you can give a more differential diagnosis kind of things, and alerts can be there, which can be definitely useful. And my feeling is that I'm just borrowing some word which when I attended a recent AI meet. Basically, the thing is that fools are those doctors who use AI as the crutch. That means the entire professional burden is on the AI. It's like a crutch. The AI need to be used like a springboard to attain higher heights. So AI you cannot be totally dependent on AI. You cannot use it like a crutch, but you should use it as springboard to attain higher heights. That'll be my take on that. Thank you.
Thank you, Ajit. So, dear friends, from here, all the discussions, one thing is clear, that AI is here to stay. But how we use the AI, how we can make the best use of AI to fulfill our goals in the critical care is yet to be seen. So till then, we have our next debate coming on 12th of February, and the motion will be, in the opinion of the House, current Indian laws are insufficient for safe EOL practice, which will be participated by Dr. Subhash Todi, Dr. Anusha Cherian, Dr. R.K. Mani, and Dr. Pratibha Ramachandran. So we will all wait for you to join with us. We will have another round of that. Till then, from all of us in GICS Face Off, the Clash of Opinions, Shubhratri, Shabar Khayat, and good night. And thank you once again to all our eminent speakers today. Thank you.
Thank you. Thank you,
so
brilliant
much.
speakers. Have a great evening. Really enjoyed
Thank
the
you,
whole session,
Pradeep,
Anirban. Thank you.
Ajit, Kapil, and Anirban for moderating, and thank you, everyone.
We'll meet you soon.
Thank you,
Thank you. Thank you,
everyone.
guys.
We will.
Thank you.
Thank you.
Thank you.
Enjoyable.